Okay, hello everyone, and welcome to our second seminar of the Surveillance Advances series 2024-2025 season, entitled From Data to Action, Cancer Surveillance and Occupational Diseases. This seminar series is co-hosted by the Public Health Agency of Canada and National Collaborating Centre for Infectious Diseases, or NCCID. My name is Signe Berger, and I am a project manager at NCCID. I will be your moderator today, along with Chayu Lin, who is a senior policy analyst in the Data, Surveillance, and Foresight branch of the Public Health Agency of Canada. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting this series with the agency. I would like to begin by acknowledging that NCCID is hosted by the University of Manitoba. Both the University of Manitoba and I are situated on Treaty 1 territory, the original lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and homeland of the Métis Nation. As a fourth-generation European settler, I am thankful for these lands that I live and work upon, and I recognize the responsibilities that I have inherited for its protection. As an organization, NCCID recognizes the systemic inequities and treaties that have been implemented as part of the process of colonization, intended to benefit some while harming others. We are committed to working with our partners towards reconciliation, and we strive to honor the lands and their original caretakers in our work. Before we dive into today's seminar, there are a few housekeeping items I would like to mention. A recording of today's seminar and the presentation slides will be available shortly after the seminar on the NCCID website at nccid.ca under webcasts. The chat box for participants is disabled for this session, but the hosts will use the chat box to communicate additional information with participants. If you have technical problems at any point during the seminar, please email us at nccid@umanitoba.ca. Please send us topic-related questions through the Q&A tab, and we'll try to address as many as possible in the discussion period. And you can also like any of the other questions to push them up in priority. We would also like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for professional development hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation, please look out for the survey that will be shared after the seminar.
Well, thank you, Cindy, for going over the key housekeeping items. Welcome and thank you for joining us today. My name is Chayu Lin, and I'm a senior policy analyst from the Data, Surveillance, and Foresight branch here at the Public Health Agency of Canada. I would like to take this time to acknowledge that I'm joining you today from Dundas, Ontario, the land where I live and work. Situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississauga peoples. This land is covered by the Dish with One Spoon, One Pound agreement. It is an agreement between the Haudenosaunee and Anishinaabe to share and care for the resources around the Great Lakes. Today, Dundas and the city of Hamilton are home to many Indigenous peoples from across the Turtle Island. We honor the Indigenous peoples who have lived on and cared for this land for generations, and I'm grateful for the opportunity to share and call this place home. At today's seminar, we have participants and presenters joining us from coast to coast to coast. The land in which they and you join us from represent the lived experiences of many Indigenous peoples, all with their own unique health story. We also like to acknowledge that the practice of public health surveillance may raise concerns for Indigenous people and other communities. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of the determinants of health and disease in populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar series, we would like to know that we use the word surveillance to refer to the assessment of and response to public health threat as a core function of our public health systems. The seminar series is not just about the speakers or organizer. It is about you, the audience. Your active participation, questions, and perspective are vital to the success of this initiative. We encourage you to engage in discussion, ask questions, share your thoughts, and foster collaboration that can lead to improvements in public health surveillance. Thank you.
Okay. Thank you, Chayu. So with excitement, I would like to now introduce and welcome our speakers. Our first presentation will be presented by Dr. Donna Turner. Dr. Turner received her Bachelor of Science from the University of Victoria in Health Information Science, followed by graduate work in epidemiology and oncology at the Universities of Calgary and Alberta, and a postdoctoral fellowship at the Manitoba Centre for Health Policy. Her portfolio at Cancer Care Manitoba includes the Manitoba Cancer Registry, epidemiology, system performance, prevention and screening programs, cancer standards and quality, and patient safety. Dr. Turner is also the scientific director of the Manitoba Tomorrow Project. Our second presentation will be co-presented by Dr. Jeavana Sritharan and Dr. Paul Demers. Dr. Jeavana Sritharan is a scientist at the Occupational Cancer Research Centre, or OCRC, based at Ontario Health. She is also an assistant professor with the Occupational and Environmental Health Division of the University of Toronto's Dalla Lana School of Public Health. She completed her PhD at the University of Toronto in the field of occupational epidemiology. Dr. Sritharan currently leads the Occupational Disease Surveillance Program at the Occupational Cancer Research Centre to examine various cancers and non-malignant diseases in the Ontario worker population. More recently, the program was expanded to include COVID-19 and opioid-related harms. Dr. Paul Demers will be co-presenting with Dr. Sritharan today. Dr. Paul Demers is the director of the Occupational Cancer Research Centre, as well as a senior scientist with Ontario Health and a professor with the Occupational and Environmental Health Division of the University of Toronto's Dalla Lana School of Public Health. He has a PhD in epidemiology and a Master of Science in Industrial Hygiene, both from the University of Washington in Seattle. Paul is internationally recognized for his expertise on the health effects of workplace exposures and has sat on many expert panels, including the International Agency for Research on Cancer working groups that evaluated carcinogens such as dusts and fibers, firefighting, and formaldehyde. Welcome, Dr. Donna Turner, Dr. Jeavana Sritharan, and Dr. Paul Demers. We're so happy to have you join us today, and we're excited to learn about your experience and knowledge in cancer surveillance and occupational diseases. The floor is now yours.
Thanks very much, Signe and CCID for inviting us to come today. So my part of today's session is to talk about cancer surveillance. So let's go to the next slide and we'll sort of go, and I have no conflicts to declare. But we're going to start with a polling question, warm everybody up. What risk factor is the second most common cause responsible for cancer? So the second most responsible. All right, so I'll let the NCCID folks let us know, and we think we've got enough polls. There we go. So the second most, so we've got lots of different votes here across the board. So let's go to survey says. the second most risk factor, being second most responsible for cancer, is actually physical activity. We're going to come and talk to them about this as we go through the presentation, but all of these things are contribute to or responsible for some cancers. So we'll talk more about that. All right, next slide, please. So, and today, my part, we're going to talk about where we get cancer data and then a little bit about what the patterns of cancer looks like and then cancer risk factors. And a lot of what I'll present is from the Manitoba perspective, which is where I'm based. But I think that what we'll be talking about is that there are cancer registries, which is the main part of what we're going to be talking about all across Canada, the US, and actually around the world as well. So that's how we know some of this. So let's move to the first slide. So one of the things that as since we have a good surveillance audience here, just to think about where cancer fits in the scheme of things that we are monitoring for public health. This slide came from the Canadian Cancer Statistics publication, what was based on data provided by Public Health Agency and StatsCan. And you can see here that even in 2020, when we were very concerned about COVID-19, that cancer was still responsible for 26% of all deaths to Canadians. And that COVID-19, which you can see on the bottom, was just over 5%. So it's really important to note that cancer is still one of the most responsible for the most deaths amongst Canadians. Next slide, please. It's also interesting to think about the lifetime probability of developing cancer. The data that I'm showing here show that about 45% of all Canadians are expected to develop cancer in their lifetime. The number is sort of wiggling up and down, sort of between 43% and close to 50%. So you're going to see this number being, sometimes you'll see 2 and 5, and sometimes you'll see 1 and 2. But the idea is that about 45% of us can be expected to develop cancer in a lifetime. And what's interesting is, for me, having been in the field for about 30 years, this number used to be 1 in 3 Canadians. So we know that more Canadians are developing cancer, but interestingly, still about 1 in 4 Canadians die of cancer. That 25% has stayed pretty standard all across the over time. So what's interesting is that although we see more people being diagnosed with cancer, we see that the death rate due to cancer is staying pretty steady, at least in terms of probability. So just means more people are surviving. All right, let's have a look at the next slide. So this is another really great slide to show. As I said, there are ways of collecting cancer data all around the world, and we use them to create maps like this. If you're ever doing a talk on cancer surveillance, I really recommend that you go to the GlobalCan or Global Cancer Observatory website by the International Agency for Research on Cancer. They've got great maps. This is one that just shows that cancer is more prevalent in westernized countries, the high-income countries, and much lower in the low middle-income countries. All right, next slide, please. And we see the same thing for mortality here. Some different patterns. You can see that about the death rates, that sometimes death rates are actually, they tend to be higher in the high income countries, but sometimes we actually see much higher rates of cancer in areas where there was lower incidence of cancer. So some interesting things to think about from an epidemiologic perspective. All right, next slide, please. So let's talk about where we get these data. So next slide. And so where we really get a lot of cancer data is from the population-based cancer registries. And in Canada, this is what we have, in the US as well. They are considered the gold standard to have a population-based registry where it's required or strongly encouraged that everybody report cancer. And certainly in Manitoba, one of the things that's interesting is that by law, under the Public Health Act in Manitoba, cancer is a reportable disease, just like many of the other infectious diseases. And in Canada, across the provinces, there are different mechanisms to support or require the reporting of cancer. There are very strict international rules on the coding of cancer, and the cancer registries submit their data to both Canadian, North American, and international sources. for both looking at surveillance on a more global basis, but also to provide evidence of the quality of the cancer data. And most Canadian cancer registries are known for their high quality cancer data. This is really a great advantage when you're looking at cancer. We actually have a process, which I'll show you a little bit more about, that really gets at those that we know clinically have cancer, not just a derived variable out of other data sets that we might have access to. One of the things that's important for you to know as surveillance folks is that there is a special international classification of diseases for cancer. It's the ICD-0, and that's not a zero. It is the ICD for oncology, and we are currently in the third edition of that, and we are looking at the fourth one coming in the next few years. So just a note that most of the time when you see coding, sometimes you'll see ICD-0 and ICD-10, but most of the cancer registries are very focused on this other form, which allows you to code by where the cancer occurs and also what type it is. So that becomes important when we start talking about different kinds of cancer. Cancer registries also include information on demographics, who the person is, their age, where they live, and then information on the tumor, all the ICD-0 coding, the stage of diagnosis, and also outcome data, and sometimes treatment. So next slide. So in Manitoba, where we get cancer registry, the Manitoba Cancer Registry is a system, but it actually also requires the care and feeding of certified cancer registrars. And these are folks who have health information management background, really, really good at digging through records, pathology reports, and other sources to get the information that they can then put into the algorithms that allow them to code for cancer. So the next slide, please. So in Manitoba, as an example, this is a pretty common example across country, or there's very much parallel examples. We are a central registry, so that means we don't have little nodes all around the province. We actually have all the information is sent to us centrally. The cancer registrars collect, abstract, classify, and use the information in order to create the coding, which then goes into the database, which for us is called Maxon. And as I said, we're mandated under the Public Health Act to collect these data. And we have cases that go back to 1930, but we became population-based in 1956. So still a long history of being able to speak about cancer on a population-wide basis. Next slide, please. So really importantly, how do we get that information? And so when I talk about all the information that comes to the registrars, we get information that comes from the hospitals and vital statistics, but a large amount of information just seen to the left here, the laboratories and electronic pathology, really, really a key element. About 90% of our cases have pathologic confirmation. So we have to have a way of getting that information to the registry. We also get access to health records, actual source records, both in the cancer clinic and elsewhere. There are sometimes letters that come in from physicians because it's legally required to report. Sometimes a physician will send us in, but that's not as common as the other sources. And then we also do share information with the provinces and territories in Canada so that an individual who has cancer has to be owned by one province or territory. That person won't be recorded multiple times. There's a lot of effort that goes into the quality of this. And then on the bottom, you can see all the things that these data are used for, and it's quite extensive. All right, next slide. So now that you know where the data comes from, let's talk about the patterns of cancer that we see in Canada as an example. The next slide. And this is information from the Canadian Cancer Statistics publication, which is an effort supported by the Public Health Agency, Statistics Canada, and the provincial and territorial cancer registries, as well as the Canadian Partnership Against Cancer, but under the flagship of the Canadian Cancer Society, who is really does a lot to bring things together and make sure that we actually have the financial support to bring together these individuals and to write these reports. And these are this information is available on the Canadian Cancer Society website under Research Statistics. But let's talk a little bit about what we see here. So this is all cancers combined, and it's really important for you to know that cancer, although we talk about it as if it's one disease, is actually more than 200 different diseases. And so what makes them all the same is that they have cells that are growing outside of control of the usual immune system type of controls. But when we look at all cancers combined, you can see that there's an east to west gradient. So cancer rates, these are age-adjusted rates, are highest in Atlantic Canada and lowest in BC. And Manitoba, where I am, is both geographically and statistically in the middle. And so you may be asking yourself, you're thinking about why is that? And we'll talk about that in a little bit in just a few minutes. So let's go to the next slide. So that was rates, and you can see that, and this slide talks about two things. One is the rate of cancer, which is the blue line on the top, and you can see that age-adjusted rates are leveling off. They actually have been declining, and they're leveling and maybe still slightly drifting down over time. But we still see many more people diagnosed with cancer because our population is aging and growing. And those two things are the biggest drivers, even in over and above risk factors that are actually driving the number of people being diagnosed with cancer. So you can see that in Manitoba, we have about 7,500 people that are expected to be diagnosed with cancer this year. And when we look in projecting forward about 20 or 25 years, you can see that we'll be up to about 12,000. The number is roughly 2% per year more people being diagnosed with cancer, although you can see when we take aging into consideration that actually levels out. All right, next slide, please. So just talking about the estimated number of new cases of cancer, so talking about Manitoba as a starting place, you can see that in my province, lung, breast, prostate, and colorectal cancer are the most common cancers diagnosed. And that, in fact, when we look at Canada as a whole, we have the same cancers there. And in fact, they happen to be in the same order. But I will tell you that these 4 cancers, which are responsible for over half of all the cancers diagnosed in Canadians, sort of juggle around a little bit. And so that it's very likely you're going to see these, but sometimes colorectal cancer will be ahead of prostate or breast. And so just be aware that that's not unexpected. And we see that quite regularly. All right, so let's have a look at the next slide. So as I said, that there are, however, many more cancers that are diagnosed. And so just so that you have an idea about the types of cancers, and when we talk about the most common cancers, you can see for men, prostate, lung, and colorectal being in the top 3. For women, breast, lung, and colorectal also in the top 3. But then you can see that there are other cancers that happen as well in amongst Canadians, and it might give you an idea then as to what might be driving those types of cancers. All right, so the next slide, just to sort of further make the point that what's happening in Manitoba is also being seen across Canada. And you can see that both the age-adjusted rates, which are in the black lines, are steady or falling, whereas the total numbers of people being diagnosed with cancer is increasing over time. All right, let's have a look next. So these kind of questions are the sorts of things which leads us to sometimes have people will say, well, you know, like, is there more cancer happening? Yes or no? So if we can have the next slide. So there does seem to be more cancer than there used to be. And as I said, 45% of Canadians are expected to be diagnosed with cancer in their lifetime, and it used to only be 33%. But we also see that those rates are leveling out. So taking a quick look on the next slide about the types of statistics that we typically use in cancer, there are, of course, when we're talking about incidence, which is the number of new cases of cancer, we can see about 250,000 Canadians diagnosed with cancer every year. Of course, we need to adjust that for the size of the population, so we could do a crude rate, but we usually do an age standardized or an age adjusted rate, and that enables us to do those comparisons over time. Okay, let's have a look at the next slide. So we're going to talk about mortality. So next slide. So mortality here is the total number of people who are dying of cancer. So this is when we talked at the beginning about 25% of all deaths in Canadians due to cancer. You can see that how it distributes over time. So again, you see a bit of an east to west gradient, but maybe not as strong as we saw before. And you can also see that some provinces like Manitoba, where I am, although we were fitting nicely in terms of the east to west gradient before, you can see that the Western Canadian provinces actually have lower mortality, cancer mortality than Manitoba. So it is certainly something that we look at. All right, next slide, please. So one of the things that's really interesting about cancer mortality when we look at it by the type of cancers that are causing death is that there's being a change is underway. So I told you in the incidence that our most common cancers were lung, colorectal, breast, and prostate. And you can see here, especially in the blue line, that we have a new player that has entered for cancer deaths, and that's pancreatic cancer. So what's happening is that we are much more successful in treating breast and prostate cancer. We're finding them earlier, and we have many more treatments that are effective. And so the rates of mortality rates due to those cancers are dropping. But prostate cancer is a very poor survival. About 10% of people with pancreatic cancer survive 5 years. So 10% survival in 5 years compared to breast and prostate, which are about 90%. And so what we're seeing is that pancreatic cancer has just sort of been chucking along at our usual level. And it is because we haven't made any improvements there. Now that we're actually making improvements in breast and prostate mortality, we're actually seeing pancreatic cancer is now the third most common cause of cancer death overall in Canada. All right, so let's have a look at the next slide. And then this is just for completeness so that when you refer back to these slides, you'll see that people do die of other cancers. And so just to show you the big list here. And one last slide, next slide, just to show the trends. This is when we talk about the success of our cancer control, which is everything we do to reduce the burden of cancer. You can see here that although the number of people dying of cancer is slowly going up, the rate is dropping dramatically. So this really does fit in with that story about the higher number of people being diagnosed with cancer in their lifetime, but the mortality rate staying the same. And you can see that the age-adjusted or the lifetime probability of mortality is staying the same. And you can see you can see this in the mortality rates. All right, next slide, please. So I just wanted to have a brief word about survival. So the next slide. And there are many ways we can talk about survival. So although mortality is about the percentage of all Canadians who die of cancer, when we're looking at survival, the denominator is the total number of people diagnosed with cancer. And we can look at that as crude survival. So basically, are you alive or not alive 5 years after being diagnosed? We could look at disease-specific survival. So did you die of cancer in 5 years or not? But we know that the coding of deaths isn't always that great. So we often use something called relative or net survival, which if you just click one more time, is a way of comparing the survival of people who have cancer with those who don't. So it's sort of more of an observed to an expected ratio. So when we look at the cancer data, you'll see that the cancer is shortening. So if your survival is 90% for a type of cancer, it means that the cancer is associated with decreasing your survival by about 10%. All right, so the next slide, let's have a quick look at what those data show. And just to know that we've made a big improvement here, 55% survival in the 90s, at 25% in the 40s, and now at 64. Okay. All right, so the next slide is going to show, and just click again, it's just highlighting Manitoba to show you those ideas about, for Manitoba, you look at here, 91% for net survival for prostate cancer, and this is very similar to the Canadian number on the top. And you can see that Manitoba does pretty well relative to some of the other provinces. Same with breast cancer. Colorectal cancer is a little bit lower, and then lung and bronchus cancer, about 22%. Manitoba used to be the leader in Canada. We used to be, we've been 22% 5-year survival for lung cancer for a long time, but you can see other provinces have now caught up with us. All right, next slide, please. So the last part of my talk is just to sort of, as I've whet the appetite of the epidemiologists in attendance, I wanted to talk a little bit about the cancer risk factors that we have. So the polling question at the top asked about what do you think is the second most common cause of cancer. So let's have a look at this next slide. This information comes from some really great work that was done by colleagues at the University of Calgary. It was supported by the Canadian Cancer Society Research Funds, and they also did a really great job, the Canadian Cancer Society, of doing infographics with the resulting information. This came from Drs. Darren Brenner and Christine Friedenreich and their team. And this is population attributable risk. So they did a massive amount of work to look at the evidence there was for what the relative risk for different risk factors for cancer would be by doing a very thorough systematic review of the literature. And then they looked at the rates, the prevalence of risk factors in each province and in Canada overall. So I would really recommend that you go to this website. It actually hops you to a more permanent website at the Canadian Cancer Society. But this is an easy URL to remember. But you can see if we were to try to eliminate cancers, if we applied everything we knew today, 4 in 10 cancers could be prevented. If we took everything that we knew that is shown here, we could actually eliminate about 40% of all cancers. Still, the number one player in the middle in the blue dot is tobacco. And so if we had to pick one risk factor we would like to get rid of, it is tobacco. But you can see here that physical inactivity is number 2. So that's where that came from in the poll. Low fruit is number 3. Interestingly separated out fruit and vegetables. So vegetables is actually number 6. Excess weight is number 4 and sun is 5. I know we're going to be talking about occupational diseases, and many of the things that you see around here are also speaking to occupational exposures as well as some lifestyle ones. And then some environmental, for example, radon in Manitoba, which is a big player, and it's been a lot of talk about radon in the last week. So this just to give you some ideas about what we know. Now, if you go to the next slide, the other thing that this study talked about was to point out that not all cancers are the same. And as I've said a couple of times already, cancer is 200 different diseases, and they all have a different suite of risk factors and that are responsible for them. So if you look on the very far right, cervical cancer represents the brass ring for us. If we could eliminate HPV, we would be able to eliminate just about all cervical cancer. There is a necessary role for HPV infection, which is why we're so enthusiastic about HPV vaccination. If you look at the very far left, you can see lung cancer, and you can see in the purple bar the role of tobacco in lung cancer. But you can see that there's other things that are also contributing and responsible, including occupation, radon, air pollution in the yellow, low fruit, and also low vegetables in the green, and some physical inactivity in the blue as well. But it's really interesting when you look across, there's some things that I think sometimes is a little bit disheartening for people. We look at breast cancer, which has a huge amount of advocacy in terms of early detection and treatment. But even if we applied everything we know, this research shows that about 28% of breast cancers could be prevented with applying what we know. So there's still a lot that we don't have evidence for. And probably the poster child for the biggest challenge award in terms of reducing cancers as a result of risk factor reduction is prostate cancer, the 4th one along, which shows that if we applied things that we knew today, right now, we would only be able to prevent about 4%. And it's the excess weight is the one that is showing there. So this is I would really commend you to look at this website and to take a closer look at what this graph shows on the website when you have a chance afterwards. So just in the last slide, to conclude that cancer is on the rise, mostly because the population is aging. And we know that because we have very good data sources on cancer in Canada and around the world. And risk factors are still quite high. And I said in Manitoba, but to be honest with you, they're quite high when we look at Canadians as a whole. And if you go and look at that website, that I showed you, you'll see that they actually, for your home province, you can actually go and look at what percentage of cancers would be able to be prevented in your own jurisdiction, province or territory. So I believe actually just province, I misspeak. I don't think territories were included. So, but it's really, and they also show Canada overall. So when we really look at how we could reduce the rise of cancer, we will not be able to reduce it without doing risk factor reduction. Cancer is a disease of aging, and so long as our population is aging and growing, we are going to see more people diagnosed with cancer. So if we want to turn off the tap, we have to do a lot better at risk reduction. All right, so that is the end of my presentation. And so Signe, over to you for the next talk.
Perfect. Thank you so much, Donna, for your amazing presentation. I'll now, for sake of time, pass it directly to Jeavana and Paul to start their presentation.
Okay, and I'm going to start us off. Can you hear me, just in case? But this presentation is really focused in on workplace causes of cancer and disease. And I'm going to just kind of introduce this, and I'm going to turn it over to Jeavana, just to say that the Occupational Cancer Research Centre was really created around the prevention of cancer. And but key to that is understanding the causes. So that's really a major focus of ours. Could I have the next slide, please? We have no conflicts of interest to report. I've just listed our funders here, which include the Public Health Agency of Canada, as well as a number of different agencies in the province of Ontario. So our surveillance program is really government funded. Could we go to the next slide, please? Our learning objectives are here. And the first one is how, understanding how to establish a surveillance program that's focused on this kind of occupational work. But we'll really be telling you how ours was created. We'll be talking about how we believe it contributes to evidence, to the evidence base regarding workplace cancer and disease, because we've expanded now to different diseases, and its impact on things like workers' compensation and other things like that. Next slide, please. So occupational cancer surveillance and indeed occupational disease surveillance has really major challenges, not only in Canada, but in many countries around the world. In Canada, we have a lot of ability to follow patterns and trends in disease, as you saw from Donna's presentation, particularly for cancer, using what we call administrative health data that is either routinely collected or, in the case of the cancer registry, targeted collection of data around disease. That's pretty comprehensive. The problem is that none of that data includes occupation or industry in Canada, so we are unable to use it to look at those kind of patterns. Even if we could, let's say, have electronic health records where there was a field for that kind of information being entered, most clinicians in Canada don't collect an occupational history. And with the possible exception of asbestos, many of them don't actually know about the causes of disease or what various exposures do cause. Oftentimes you hear workers' compensation data quoted, and it only captures a small fraction of that. I'll talk about that in a minute. And much of our other data really is much smaller sets of data that don't really give us the big picture that we need for surveillance, or if it does provide a picture, it has very limited information on occupation and industry. Let's go to the next slide, please. Now, historically, not only in Canada, but in other places, death certificate data was often used, because on death certificates, often and in many different jurisdictions, there'll be a place for when a person dies, that they mark their usual job in life, or at least to the knowledge of the person filling out the death certificate. And you see here a couple of examples, one old one from BC, and one that was done nationally. Problem is that mortality data does not often collect does not really collect very accurate information. The other survey you see here from Canada was from another survey. It was a large survey, but it's hard to get a survey big enough. There's so many different jobs that people hold, so many different industries that people are employed in. It's hard to get a data set big enough to really give us that kind of detailed picture. Can I see the next slide, please? Now, this is just an example from workers' compensation data in Ontario. Now, we've analyzed a lot of this data over time, but I think our estimate is that about 5% or less of all occupational cancers are actually captured by workers' compensation. So it gives you a very limited view of what's going on. You do see things like mesothelioma because it's caused by asbestos, and it's the only thing pretty much that causes mesothelioma, or almost the only thing. So that you hear a lot about. But for other lung cancers and other types of cancers, we're really not getting a full picture. And then you can get things like this that are misinterpreted. What they're showing is that more of these cancers are being recognized, and oftentimes instead it's interpreted that occupational cancer is on the rise. And it may or may not be, but these kind of data don't really give us that kind of a picture. Next slide, please. We do use cancer registry data, and we use it, though, primarily for record linkage. The only exception that I can think for that is for looking at mesothelioma, because we do know that it's caused by asbestos, and we can monitor trends there and know that it has been increasing over time. It's only recently leveled off here in Canada, and despite their ban, we still have many cases of asbestos-related cancers. And you can see that the rates here vary a lot geographically. So we can do a lot with this, but it doesn't really tell us where that exposure to asbestos occurred. Can we have the next slide, please? Now, the one large data set that we have in Canada that is national, that collects occupation industry, is the census. That certainly is the biggest one here. And over time, some of these censuses, I'm going to say censuses, I'm not sure which is proper English, have been linked to the health records of the country, including the Canadian Cancer Registry, the Canadian Mortality Database, and other data sets. And about 2 million people, for example, in 1991 were successfully linked and actually had occupational information. But what we find is that we're not even seeing, associations between high-risk occupations and cancer sites that we know exist. And we suspect that's because in some of these large data sets, the coding of that occupation data is quite limited. Next slide, please. To address this gap, we started what's called the Occupational Disease Surveillance Program at our center. And we developed it with funding from the Workers' Compensation System in Ontario, the Ministry of Labour, and the Public Health Agency of Canada. And since then, the Ministry of Health in Ontario has also weighed in and supported us. And what we're going to talk about particularly today is the Occupational Disease Surveillance System, which is a system we created specifically to be able to look at patterns of occupational cancer and disease. And with that, I'm going to turn it over to Jeavana, my colleague.
Paul, next slide, please. So we established the Occupational Disease Surveillance System at the OCRC, and it contains information on approximately 2.37 million Ontario workers. So here you can kind of see a nice infographic where workers are first identified in the Workplace Safety and Insurance Board, WSIB, accepted lost time compensation claims records from 1983 to 2019, and more recently we updated this to 2022. So this WSIB file is very important because it contains information on the accepted lost time claims for a work-related injury or illness for workers in Ontario. And so this is where we identify a worker's employment information through their reported occupation or industry. And all 2.37 million workers in the WSIB data set are then linked to the registered persons database. So this would give us some of their personal characteristics, also death date, if they immigrated out of Ontario, and residential information. But more importantly, it gives us health insurance number, which we can then use to link to health records. So then the workers are linked to various health information sources that are listed here. So you can see the Ontario Cancer Registry, hospital emergency department visits, doctor visits, and lab test results. And this is where we sort of have the ability to look at different outcomes based on whatever information source we're using. Next slide, please. This is to give you an idea of the various outcomes we've looked at. Not all of the things we've looked at are listed here, but just to give you an idea of the common and rare cancers that we can examine in the ODSS. We've also been able to examine various non-malignant diseases. These are determined based on sort of advisory committees or input from system partners and stakeholders. And more recently, we added opioid-related harms and COVID-19. And the next set of slides are going to show you examples of what we've been able to do in the ODSS. Next slide, please. The first being lung cancer. So we know that lung cancer is the most common cancer in Canada. And although we know smoking is the main cause of lung cancer, we also know that workplace exposures are an important contributor. And it's estimated that 15% of lung cancers are due to known or well-studied workplace exposures. So our center released a report on the burden of cancer in previous years, outlining asbestos, crystalline silica, diesel engine exhaust, and welding fumes as the most important lung workplace carcinogens in Canada. Next slide, please. In our surveillance system, we identified specific occupation and industry groups that had the highest risk of lung cancer. And so many of them are highlighted in the figure here. So for example, you can see that within construction workers, we identified insulators as having the highest risk of lung cancer in our cohort of workers. And we know historically these workers handled asbestos containing materials. We know they may be exposed during renovation, repair, demolition of older buildings, etc. And so our job is to sort of figure out which are the groups that are deemed as high risk or at higher risk than other groups and sort of what their exposures would be like. Next slide, please. So what we do in addition to producing a lot of these results is the knowledge translation aspect of it is very important for us. So for this project, we worked with the Canadian Centre for Occupational Health and Safety to develop an Ontario disease statistics tool to identify workers at risk of hazardous substances in the workplace. And the two examples that I'm showing you here are showing you different ways we can approach the data. So on the left side, you can see it by sector, so mining sector, and on the right side, you can see it by exposure, so exposure to asbestos. And these infographics share information about the workers in our surveillance system, but also share exposure data from the Ontario population and which groups have the highest risks. So you can see here that lung cancer is a key outcome for the mining industry, but also for asbestos exposure. And often we want to understand sort of who are these workers, what are their exposures in relation to a specific outcome like lung cancer or the other ones that are listed here. Next slide, please. Another area of research that we've significantly contributed to with our surveillance system is really the cancer among firefighting. And Paul and other colleagues at the OCRC were involved in the IARC working group that recently evaluated firefighting and cancer. And our study from the surveillance system was included in this evaluation. And we know that firefighters are exposed to both fire-related cancer-causing agents and non-fire-related cancer-causing agents. So heavy metals, polycyclic aromatic hydrocarbons, shift work, diesel engine exhaust. But much of the evidence is predominantly on firefighters and followed by police as well, where we've been able to look at potential cancer risks and exposures that are involved. We've expanded our scope to look at police and paramedics to understand if cancer risks were different or similar among these emergency service workers. And our research was actually the first to examine cancer risks among paramedics and the first scientific paper on these workers in Canada. Next slide, please. So this figure reports the risk estimates for the three different groups, so police, firefighting, and paramedics. And you can see that where I've highlighted the higher risk groups are for any cancer, melanoma, prostate, and then you see a reduced risk for lung cancer. So when we're looking at prostate cancer and melanoma, much of the research related to occupation is based on firefighters. And so really that's where the evidence is. And although it's unclear as to what exposures are related to prostate cancer in firefighters, we know that there's few factors that are suggested, specifically night and rotating shift work, which are common among emergency service workers and have been suspected in prostate cancer development, similarly to breast cancer. With melanoma, there are potential risk factors. We know that emergency service workers are outdoors during calls, for training, for performing errands. They could be exposed to PCBs through inhalation or dermal absorption when they're near fire and smoke. We also know that based on ethnicity, light-colored skin is a known risk factor for melanoma. Unfortunately, in our system, we don't have information on ethnicity, nor do we have sufficient information on ethnicity among Canadian firefighters. This is generally not information that's collected. We also observed a decreased risk of lung cancer, which was slightly surprising because we know there are respiratory carcinogens that are among all three groups, and more so for firefighters. But this may be attributable to reduced cigarette smoking habits. We know that these workers have physically demanding jobs, and we know that they undergo various evaluations prior and during employment. But these are all hypothesized as to why we're seeing these different sort of cancer risks among these different workers. Next slide, please. So overall, there were some striking similarities, especially for melanoma, prostate, and lung cancer. And despite the differences among job tasks for these different workers, the similar elevated risk may actually indicate shared exposures such as shift work, vehicle exhaust, solar radiation, and potentially fire smoke contaminants when they're working together or in proximity to fires. Next slide, please. So another key project of the surveillance system was in partnership with the Institute for Work and Health, and it is our opioid-related harms project. This was the first study to examine work information, so both work information and opioid-related harms through health records in Canada. And this project has continued to be an interest to stakeholders, system partners, the public, in particular the media. So the graph on the right shows you the breakdown of deaths by age and sex, in this case in 2022. And although the patterns are generally similar year after year, what we're seeing is that males of working age have a higher risk of opioid-related harms and are maybe disproportionately affected by the current opioid crisis. And so there's a greater interest in understanding whether occupation or the workplace environment has a role to play in why we're seeing these patterns. Next slide, please. So our system has the ability to not only examine 3 opioid-related harms that we can identify in health records, but also specific to poisonings. We can actually look at the intent of poisoning among workers in our surveillance system. So this gives you an idea of what type of data we're able to capture, and often it aligns with what we're seeing in the Ontario population. So you can see a sharp increase here in 2016 and onwards, specifically for accidental poisonings, which is in line with the increase in synthetic opioid use, specifically fentanyl contaminated drug supply. And so that gives us an important signal that we're seeing really similar patterns in our surveillance system to what we're seeing in the Ontario population. Next slide, please. So we've done various analyses to examine the risk of opioid harms among the workers in our cohort. We've done various analyses to compare them to other workers, to compare them to the general population. So if you click a few more times, you'll see the top occupational groups listed here with a higher risk of opioid-related harms. So if you click again, there we go, thank you. So what you're seeing here is our top 8 groups with consistently higher risks of opioid-related harms that we can see in our surveillance system. And one group here, construction and trades, is often regarded in the media and other literature, but these other groups are less studied and less well understood. And so the purpose of our surveillance was really to understand, are we seeing similar findings for groups that have been previously identified, but also new findings, so identifying other high-risk groups. We can also dig deeper within each of these sort of high-level groups like construction and trades and look at this by job title to understand which groups have a higher risk. Next slide, please. And based on our findings, there's been many hypotheses to why we're seeing what we're seeing, and mainly that high-risk groups that we're seeing are in physically demanding jobs, which increases the risk for injury and results in various scenarios listed here. And it can be very challenging to unpack some of these complex issues surrounding patterns of harms that we see in this work, similar to other diseases that we examine when there's very little literature out there or little known, or where there's multiple risk factors involved. Next slide, please. So this project has had a large knowledge translation component, and we developed our website to share scientific findings, accompanying summaries, infographics. We also created our own data visualization tool. So you can go in and look at the case counts, the rates, and explore this by various factors such as occupation. And you can see the websites are all linked in, so you're welcome to look at this once you receive the slides. Next slide. Thank you. So the last project I'm going to talk about is our COVID-19 work. So this involves not only hospital records, but also the lab test results that we have available that we've linked into our surveillance system, specifically PCR test results. And so we were able to do this for our COVID-19 project to identify which groups of workers were at a higher risk of infection compared to other workers or compared to the general population. We, of course, expected to see healthcare workers at the top of our list. So you can see nurses listed as the third highest risk here. But we also know that, you know, these are workers who potentially had better access to testing and frequency of testing. Next slide, please. So what was more interesting for us was to look at the hospital records as opposed to looking at the lab test results to understand if individuals had visited the ER or hospital due to COVID-19. So this being their main problem and entering the hospital for this. And we deem these workers as having severe COVID-19. And so again, you can see similar groups that are listed here, but there are also other essential workers beyond nurses that are listed that are very important for us to explore, so that, you know, this work is not only important for just COVID-19, but really to potentially steer prevention efforts in the future so that we can identify and understand disease transmission within the workplace and outside of the workplace among workers. So I'll just quickly point out that our system does have limitations, such as a lack of non-occupational risk factors for disease. But what we're doing is trying to work towards filling these gaps and limitations, and filling the gaps where there is really no literature available among these workers in Canada as a whole. And right now we're working on additional linkages and bringing in exposure data so that we can improve occupational disease surveillance. And next slide, please. Great, so thanks for listening to our presentation. We do have a number of websites that are listed here where you can find all of our scientific publications and accompanying summaries and infographics. Thank you.
Well, thank you so much, Donna, Jeavana, and Paul, for your insightful presentation on the cancer surveillance and occupational disease. We're very close to the end of time, but I think we may have 1 minute to take one questions. We will go with some of the questions that was submitted during the registration. And this question will be for either Paul or Jeavana. 1 second here. So the Occupational Disease Surveillance System that you mentioned, the ODSS, was recently expanded to monitor the occupational patterns of opiate-related harms and also the COVID-19 infection and effects. How agile is that system in terms of responding to future public health threats, and what are the contributing factors to its agility?
Want that, Jeavana, or you want me to?
You can start, and then I can just add in a comment if there's.
I'd say it relatively is. I mean, the limitation is that our system has to hook into other health records that actually would provide us a good picture of it. So there are things, you know, if I name one very common workplace issue, you know, hearing loss, it simply doesn't captured well within the administrative health data, where some types of other chronic diseases are. So it really is dependent upon the kind of general ability to track a particular disease or health outcome within using our health records in Canada.
Yeah, and I'll just quickly add that we're feeding multiple health record databases into this, and we often work with everything we have to identify the case definitions and sort of go through what the limitations are. So even with COVID-19, we know healthcare workers were tested more frequently. So understanding how we can sort of manipulate the analysis to understand how to account for that, but also being able to use the records and the information we have. And there's obvious limitations to it, but I think we're trying to improve surveillance in Ontario, and that's what we've been able to achieve so far.
Thank you very much. We're almost right at time, so I'm going to pass it back to Sydney.
So thank you so much for joining us in today's seminar. And thank you to our speakers, Dr. Donna Turner, Dr. Jeavana Sritharan, and Dr. Paul Demers for their fantastic presentations. Reminder that the recording and presentation slides will be posted on our website. And please join us for our next seminar on Tuesday, November 26th on wastewater monitoring in northern and remote areas, the EOHG experience. Next slide, please. And there is also another upcoming webinar organized by NCCID and the Canadian Association for Immunization Research, or CARE. This webinar is on vaccine safety surveillance in Canada, opportunities for equity. So you can scan the QR code on this slide to register and for more information. And lastly, next slide, please. Please take time to complete our post-seminar survey. You can scan the QR code on this slide to access the survey. And in this survey, you can also request a letter of participation if you would like. That concludes today's seminar. Thank you all for joining us, and I hope to see you next time.